It's a pleasure for me to introduce Dr. Stefano Ciardullo, physician and researcher in endocrinology and metabolic diseases at the University of Milano Bicocca and Policlinico di Monza. Dr. Claudio's research focuses on the intersection between metabolic dysfunction, diabetes, and liver diseases, particularly on the epidemiology and non-invasive assessments of metabolic dysfunction associated steatotic liver disease. He has authored more than 80 peer-reviewed publications with over 1,500 citations, and his work has directly contributed to shaping international recommendations, including the American Diabetes Association's 2023 Standard of Care on Liver Diseases Screening in Diabetes. Dr. Ciardullo has received several national awards from the Italian Society of Diabetology, including the Umberto Di Mario Prize and the Galeno Prize, recognizing his contributions to translational research in diabetes and liver diseases. Beyond research, he is deeply involved in academic teaching and scientific communication, serving on the editorial board of journals such as Cardiovascular Diabetology and Frontiers in Endocrinology. Please join me in welcoming Dr. Stefano Ciardullo, whose talk will shed light on the evolving landscape of metabolic and hepatic disease, particularly on the screening for MASLD-related advanced fibrosis.
Okay, thank you very much. It's really a pleasure for me to be here. I will try to share the slides. Just let me know if you can see the screen, if you can see the presentation. Can you see it?
Not yet, but it's coming, I guess.
Okay.
Now, yes.
Okay, thank you very much. So it's really a pleasure to be invited here to deliver this talk. As you can see, I entitled my talk Screening for MASLD-related Advanced Fibrosis, Finding the Needle in the Haystack. These are my potential conflicts of interest that really have nothing to do with what I'm going to talk to you about today. So this is the agenda. We will start by looking at the epidemiology and natural history of MASLD or NAFLD, as we want to call it. Then look at how we can predict clinical outcomes. Go back to 2018 when I first started approaching this topic, and just to show how the landscape has changed from back then, and look at how guidelines now recommend screening and specific algorithms. And finally, we will end with some open questions and unmet needs. So first, epidemiology and natural history. Well, it is very well known that MASLD is the most common form of chronic liver disease worldwide. These are data from a meta-analysis from Yunusi and colleagues. And as you can see, not only is the most common cause of liver disease, it is also increasing in prevalence in recent years, going from 25% of the general adult population in 1991 to 2006, up until 38% of the general population being affected by MASLD in the most recent studies. Therefore, a real pandemic paralleling the pandemic of obesity and type 2 diabetes. And as you can see, focusing on patients with type 2 diabetes, which has been mostly the focus of my research as an endocrinologist and a diabetologist, of course, the prevalence of liver steatosis in this population is even higher. Again, data from meta-analysis, a little bit older meta-analysis showed that, for example, in Europe, 68% of patients with type 2 diabetes have liver steatosis or MASLD. And most importantly, patients with type 2 diabetes tend, of course, to progress faster compared with patients with steatosis but without diabetes. And they have a much higher prevalence of MASH, so steatohepatitis, and of advanced liver fibrosis, making liver disease a significant contributor to mortality even in patients with type 2 diabetes. Of course, MASLD is an umbrella term. We have patients with very different degree of severity under this large term, going from simple steatosis, as you can see on the left, and this is taken from a review we published in 2021. And as you can see, patients can progress to inflammation. They can also regress, and they can progress to different degrees of liver fibrosis, and ultimately, in a minority of patients, to cirrhosis, decompensated cirrhosis, or hepatocellular carcinoma. And as we know, there are also some patients that can develop HCC without full-blown cirrhosis, which is very difficult to manage. In terms of histologic features, there are three main histologic features that are important to keep in mind, because, of course, also screening modalities only look for one of these different features, and these are, of course, steatosis, the degree of fat infiltration, inflammation, so steatohepatitis, and as we all know, there are no well-validated non-invasive biomarkers to identify inflammation, and of course, fibrosis. I entitled my talk Finding the Needle in the Haystack because, of course, most of the patients affected by MASLD will not die of liver-related events, but most of them will die of other causes of death, such as, of course, cardiovascular disease and cancer, extrahepatic cancer. But still, a few can progress, and given the huge number of patients affected by MASLD in general, even this small proportion leads to MASLD being one of the most common causes of end-stage liver disease. And so we have to keep in mind that, of course, our patients should be followed in a multifactorial way to also address metabolic alterations and, of course, cardiovascular and renal disease. And this is very well shown by this cohort study, multinational, with 600 patients with biopsy-confirmed NAFLD, which were followed for 13 years. And as you can see, among the deaths that occurred in these 12 years, most of them were related to cardiovascular disease and non-liver cancer, with liver disease contributing to 7-8% of all mortality. But this is also dependent upon, of course, the stage of liver fibrosis, because as we increase the degree of fibrosis from F0 to F4, then, of course, the liver-related causes of death tend to become much more common, even in relative terms, so much so that, for example, in patients with F3, the incidence, the mortality related to liver disease is similar to that related to cardiovascular disease. And of course, in patients with cirrhosis, liver disease becomes the most common cause of death. So we need to screen, we need to identify these patients with more advanced forms of the disease in order to try and prevent this excess mortality that is well shown on the right side. This is a very large study based on biopsy performed in Sweden. So what's the best predictor of clinical outcomes in patients with MASLD? This has been shown over and over again in different cohort studies based on liver biopsy or even on non-invasive biomarkers. As it occurs with most chronic liver diseases, the degree of liver fibrosis is the best predictor of death, not only related to the liver, actually, but also of all-cause mortality. This is a very important study published in the New England Journal of Medicine in 2021 from the US. And as you can see, the mortality risk, the all-cause mortality is much higher in patients with advanced liver fibrosis, so F3 and F4, compared with those with steatosis, but without significant liver fibrosis. And so this has been replicated in several studies. And just to summarize them, I show you here two of the most recent meta-analyses and most comprehensive, showing a progressive increase in the risk of all-cause mortality with increasing risk of liver fibrosis, as you can see on the left in the meta-analysis by Dulai and colleagues. But this is also true in the later meta-analysis from Taylor and colleagues. And as you can see, stage 3 has more than doubled the mortality compared with patients with F0. And of course, patients with F4 with cirrhosis have a more than 6-fold increased risk of dying from liver-related events. And so the field has very much focused on fibrosis as the the clinical and histologic features to try and identify even non-invasively in clinical practice. And so I will try to go back in time to 2018 when I first started to approach this topic to show you how things have changed based on also on international guidelines and evidence that even our group a little bit has generated and how it changed the way guidelines modified their recommendation. So back when I was a first year resident in endocrinology and diabetes, of course, I immediately realized that when we sent our patients with type 2 diabetes to perform an ultrasound of the abdomen, more often than not, the results were that they had some degree of liver steatosis. But what I found in everyday clinical practice is that we didn't really do anything about it, rather than put it in the patient's chart and maybe perform another ultrasound in a couple of years. But most clinicians, most diabetologists did not actively do anything specifically for the liver. And indeed, the scenario back in 2018 was a little bit controversial because, as you can see, and here I summarized the most influential guidelines from, at least for the Western world, back in 2018. As you can see, the American Association for the Study of Liver Disease did not recommend screening in a routine term, even in patients with metabolic diseases such as type 2 diabetes, but called for case finding. A very different approach was suggested by the European guidelines, these joint guidelines published in 2016 from the European Association for the Study of the Liver, Diabetes, and Obesity, so multifactorial guidelines. And they did recommend to screen for NAFLD in patients at high cardiovascular risk, including type 2 diabetes or metabolic syndrome. And these guidelines have the great advantage, in my opinion, to also show you how to perform this screening in everyday clinical practice, and we will focus on that in a few slides. But then, of course, also the ADA standards of care kind of recommended screening in patients with type 2 diabetes with elevated ALT or fatty liver on ultrasound, even though they did not give very specific, very exact recommendations on how we should perform this screening. And just to show you, I started to look at this topic because I was interested to know why years after these guidelines were published, they were not really followed in everyday clinical practice, at least in the diabetes unit. So this is the algorithm that was proposed by the 2016 European guidelines. As you can see, the first step was to look for the presence of liver steatosis using ultrasound or in large, let's say, epidemiologic studies, even using steatosis biomarkers. And then it was based on liver enzymes, the presence or absence of abnormal liver enzymes, and the use of serum fibrosis biomarkers. Of course, these were recommendations related to the identification of MASLD, or as it was called back then, of course, NAFLD. As you can see, in patients with type 2 diabetes, the presence of NAFLD should be looked for irrespective of liver enzymes, since patients with type 2 diabetes are at high risk of disease progression. And ultrasound, of course, was the preferred first-line diagnostic procedure for imaging of NAFLD, as it provides additional diagnostic information. And here I summarized data on the sensitivity and specificity of ultrasound to detect steatosis on the left. These are from a dated, let's say, meta-analysis from Hernandez and colleagues from 2011 that told us that, of course, ultrasound is operator dependent, and the sensitivity to detect steatosis of any degree, so fat infiltration in at least 5% of hepatocytes, is not so high. But it increases, of course, if we are interested in high degrees of liver steatosis, while the specificity of the technique was very good. And so if the radiologists tell us that there is steatosis, we can trust him. And on the right, you can see similar data in terms of sensitivity and specificity related to the control attenuation parameter that, of course, we can obtain from a fibroscan examination together with liver stiffness, showing that sensitivity and specificity are probably not optimal, but still quite good, and is a little bit less operator dependent compared with ultrasound. Once we found liver steatosis, the guidelines told us to refer to the specialist all patients with abnormal liver enzymes, or if the patient had normal liver enzymes, we should look for serum fibrosis biomarkers. And based on this, of course, if the risk of fibrosis was low, we could follow them up in a couple of years, compared with patients on the other side who had a medium or high risk of fibrosis, who should be referred to the hepatologist for a more in-depth assessment of disease severity. This table summarizes a little bit the available markers that were also mentioned by the guidelines. The two most validated ones were fibrosis 4 and NAFLD fibrosis score, but they also showed other potential biomarkers to use in order to perform the screening, and also which cutoffs we should use to identify patients with advanced fibrosis, or I should say which cutoff we should use to exclude advanced fibrosis, as this is the main purpose of these serum biomarkers. And so we should keep in mind that these biomarkers have generally good negative predictive value, as shown in this meta-analysis, more than 90%, in some studies even 95%, whereas the positive predictive value is a little bit, of course, dependent upon the prevalence of advanced fibrosis within the population, but is never higher than 60%. So we will have at least 30-40% of false positive results, even using high cutoffs, for example, for FIB4, such as 2.7 or 3.3. And what I asked myself back then is, well, of course, the guidelines recommend to use one of these fibrosis biomarkers, but does it make any difference which one I use in my everyday clinical practice? And so I went back to our database of patients with type 2 diabetes that we followed from 2013 to 2018, and almost 3,000 patients, unselected, which was very important. And as you can see, we could, for example, comparing FIB4 with NAFLD fibrosis score, with FIB4 we could exclude advanced fibrosis in 53% of our patients, whereas with NAFLD fibrosis score, we could exclude advanced fibrosis only in 13%. And this resulted, of course, in a very different proportion of patients that we should, of course, refer to hepatologists for a more in-depth assessment of liver disease. And of course, probably this is related to the fact that NAFLD fibrosis score incorporated diabetes and BMI as as two of the variables that were used for the calculation of the score itself. So in order to look at whether my data were actually representative of the general population of type 2 diabetes, I went to the NHANES database, which is, of course, a very large cross-sectional study, very famous study performed in the United States. I just focused on patients with type 2 diabetes, again, almost 3,000 patients, representative of approximately 15.3 million patients with type 2 diabetes in the US. And by applying, this is exactly the algorithm proposed by the EASL, ESD, ESO guidelines. As you can see, we should refer to specialists either because of abnormal LFTs or because of an increased risk of liver fibrosis. Approximately 50% of patients with type 2 diabetes, which is probably not that feasible in everyday clinical practice. And this is something that was already described in an interesting study from France back to 2017 in the setting of severe obesity, as you can see from the group of Professor Cousy, 390 patients with severe obesity, which were referred to an endocrinology department. They also applied the same algorithm proposed by the European guidelines. And as you can see, 75% of their patients should be referred to hepatologists, which probably isn't the best way to go, as hepatologists should, focus on those patients that really have a high risk of progression to advanced fibrosis. And so these data like these helped us move from a one-tier, let's say, algorithm based only on non-invasive blood biomarkers of liver fibrosis to different screening algorithms based on on two specific steps. And these were already present in 2021 in the EASL clinical practice guidelines. As you can see, the first thing that we should do is to calculate FIB4. So this time, the guidelines focused on a single biomarker in order to reduce, the number of false positives that we can get, for example, with NAFLD fibrosis score. And then for patients with a FIB4 greater than 1.3, these are not all referred to a specialist, but a second tier test is to be performed. And the most widely used, of course, is liver stiffness by transient elastography. And using this 8 kilopascal cutoff, we can then even further risk stratify our patients, and this should result in a lower number of referral, but still have enriched this referral population with patients with advanced liver fibrosis, or at least this was the purpose of the guidelines. So first of all, FIB4, and then a two-step strategy followed by transient elastography. Of course, there are several elastographic techniques that are available in clinical practice. The first and most validated, of course, is VCTE, vibration controlled transient elastography. Now there are many ultrasound machines that incorporate, as you know, softwares to perform point shear wave or two-dimensional shear wave elastography. a little bit fewer studies available on these platforms, but some of them work quite well. And of course, a very well performance, but low accessibility for magnetic resonance elastography. Just to show you some of the data that I mentioned before, here is a large meta-analysis in 2021 to look at the sensitivity, specificity, and general accuracy of these techniques. As you can see, there were a lot of studies with VCTE showing a good degree of association with the degree of liver fibrosis measured with biopsy. Good accuracy also for point shear wave, a little bit less so with two-dimensional shear wave, and very good accuracy with magnetic resonance elastography, which is not available in most countries in Europe. Of course, all of these non-invasive biomarkers have advantages and disadvantages. For example, FIB4 is very available, very easy to calculate, AST, ALT, platelets, and age, low cost, and a lot of studies performed with it, but the area under the curve is not so high, does not work very well in very young patients or in very old patients. On the other hand, VCTE has a better accuracy compared with FIB4. Of course, the availability is a little bit lower compared with FIB4, of course, and there are some technical limitations related, for example, to very high BMI levels, active inflammation, food intake, cholestasis, heart failure, or an inexperienced operator. And these should all be taken into account when interpreting these results. So I went back again to the enhanced database to look at the prevalence of advanced liver fibrosis in a population of patients that were not selected at all to begin with. And these were 800 patients with type 2 diabetes from the general United States population. And as you can see, the prevalence of steatosis with a cap greater than 274 decibels per meter was 73%. So 3 out of 4 patients with type 2 diabetes had evidence of liver steatosis, and this was in line with previous studies. But what was really interesting was that, for example, 24% of all patients had some evidence of fibrosis, with 7.7% having some evidence of possible advanced fibrosis, and even 8% with unknown cirrhosis. And so I was a little bit, preoccupied with these results. So I went back to the literature to look at whether our estimates were in line with other studies performed in this patient population, patients with type 2 diabetes. And we performed this meta-analysis in 2022, looking at 28 studies for a total of more than 10,000 patients with type 2 diabetes, and the prevalence of significant liver fibrosis based on VCTE. These are all VCTE studies. Of course, the cutoffs changed a little bit, but not so much. So going from 7 to 8, 9.6, something like this. And the prevalence was 19.8%, and it was quite similar across countries. As you can see, 18% in America, 20% in Europe, and 19% in Asia, showing that actually a significant proportion of our patients with type 2 diabetes have evidence of significant liver fibrosis. And this was also shown in 2 very important studies in the field, one from France, one from the United States, based on liver biopsy, who showed an even higher prevalence of advanced fibrosis and NASH. One could argue that this may not be completely representative of all people with type 2 diabetes, because there were some, inclusion and exclusion criteria, especially in the French study. But as you can see, approximately 9 to 10% of patients still have evidence on liver biopsy of unknown full-blown cirrhosis, and 30% had evidence of advanced liver fibrosis, which is something that, in my opinion, we do not appreciate very much in everyday clinical practice, because most of these patients probably have compensated the cirrhosis, and we then miss them for a lot of years. And then when they, of course, decompensate, maybe us as diabetologists, we do not see them anymore because they are always in the hospital, or they are followed by other clinicians. And of course, these data are really strong, showing that these patients should be really looked for the presence of advanced liver fibrosis. And based on this data, and data that, of course, I couldn't show you all the studies, epidemiologic studies that were performed in the last 5 years, as you can see, all of these international guidelines that you can see on the right have really now are performing the same recommendation, the same screening algorithms. There is a strong agreement across all guidelines that patients with type 2 diabetes, or in general patients with metabolic syndrome, obesity, and so on, should be screened for liver steatosis. And FIB4 is the first line test, as we summarized in this review. And if higher than 1.3, a second line test, so VCTE, MRE, or ELF, depending, of course, on whether it is available or not in your country, should be performed. So this two-step algorithm has been supported by most of the international guidelines. And of course, nowadays, when they ask me what's the point of identifying these patients, whereas before I could only say that we should, know about advanced fibrosis in order to perform, for example, screening for HCC and so on. Nowadays, we start to have treatment options available. And of course, us as diabetologists are quite familiar with these drugs, and we are already using them in patients with type 2 diabetes, in patients with obesity. But it's important to know whether the patient should also receive these drugs for advanced liver disease or not. Of course, I'm talking about incretins, GLP-1 receptor agonists, double agonists, and so on. And of course, also resmetirom, where it is available. Well, does this two-step strategy really reduce the number of referral to hepatologists? This was evaluated in a recent study published in CGH this year from the group of Professor Casterà. As you can see, 1,500 patients with type 2 diabetes and a subset of patients with liver biopsy. And as you can see, the number of referral to the hepatologist using this two-step pathway was approximately 12%, so much lower compared with that 48% that I showed you before when we applied the 2016 EASD-ASO guidelines. So this works well for reducing referrals. And of course, this is also, and we will talk about this later, reducing referral is an important outcome. But of course, I want to refer the right patients. So I want them to have a high prevalence of advanced fibrosis in those that I refer. But most importantly, I want to be able to get most of the patients with advanced fibrosis. So I'm looking for very low false negative results, and this is not so much the case with this two-step strategy. And we will talk a little bit more about this in a few slides. But the other thing that I ask myself is, of course, we are able to identify patients with advanced fibrosis using transient elastography. But is transient elastography as good as liver biopsy in predicting outcomes, so mortality or end-stage liver disease in patients with MASLD? And so to do so, I did this meta-analysis of six studies, cohort studies that performed VCT at baseline and then followed the patient. And as you can see here, of course, there is a little bit of difference based also on the cutoffs that the authors reported for advanced fibrosis. But still, there is a very strong association between liver stiffness, elevated liver stiffness, and mortality. And in another recent study, and this was a single patient meta-analysis, the authors showed that baseline liver stiffness is similar to liver biopsy in its ability to risk stratify patients according to their risk of dying. And so the field, of course, is moving a little bit away from liver biopsy in everyday clinical practice, of course, because it is not feasible to perform in a large number of patients. But what it seems is that we are not missing diagnostic potential by doing so. And liver stiffness has a similar area under the curve, as you can see on the top of the screen, compared with histology to predict outcomes. And this is a very important aspect. Still, we do not know everything about the best way to screen our patients. There are still some open questions and unmet needs. One that I alluded to before is the rate of false negative results. You know well that the best feature of FIB4 is its high negative predictive value. So the ability to exclude advanced liver fibrosis when the value is below the low cutoff, so 1.3 in younger patients or 2.0 in older patients. But in this study, the same study that I showed you before from the group of Professor Casterà in 1,500 patients with type 2 diabetes, if they performed fibroscan in patients with a low FIB4, which is not recommended by the guidelines, still 19% of these patients had an elevated stiffness, meaning that probably we are missing some patients. As of course, 69% of patients have low levels of FIB4, which is similar to our population, and 90% of these 69% actually have an increased liver stiffness, which might not translate, of course, in all cases to advanced fibrosis on histology, but still we are missing probably a number of patients by using this two-step strategy. And the number of referrals was 12%. And what is very interesting is that in the same population, they looked at a different strategy, which in my opinion could be quite good as well, at least in patients with type 2 diabetes, which is just starting with VCT first line in all patients. And as you can see, with this approach, they would refer 19% of patients, which is exactly in line with the meta-analysis that we published before. 19.8% of patients with type 2 diabetes have a stiffness greater than 8 kilopascal. And then they looked at the performance of this screening algorithm in a subset of patients with available liver biopsy. And what they showed was that they had a very low false negative rate, and the false positive rate was 49%, but still, this means that we are referring to the hepatologist patients with a prevalence of advanced fibrosis of 49%, which is good, in my opinion. It's normal to have some false positives. Otherwise, if we were sure of all the patients that had fibrosis, we wouldn't need to screen this way. And so I do agree with the authors that this might be a better algorithm, of course, if VCT is available and to be applied to all patients with type 2 diabetes. And of course, this has to do with the importance of the pretest probability of disease. As you can see, the prevalence of advanced liver fibrosis in primary care, for example, is less than 10%. In the diabetes clinic is between 10 and 20%. And in the liver clinic, it is usually higher than 20%. And as the pretest probability of advanced fibrosis increases, then of course, so does the positive predictive value of this test, with FIB4 being still a little bit low, 54%. But most importantly, the negative predictive value tends to become lower. And for example, in the field of diabetes, in accordance with previous studies, we can see that the negative FIB4 probably misses 10% of patients with advanced liver fibrosis, and these patients, of course, need to be identified. There are still some other open questions that I am not going to be able to address in a very precise way. I will just mention them in this last slide. So there is still no specific invasive biomarker to evaluate the presence of inflammation itself, MASH. All of our biomarkers focus mainly on fibrosis. There are some biomarkers of at-risk MASH, but still they are still not yet recommended in their use in clinical practice. It's important to evaluate how frequently to perform serial assessment and whether it is really able to improve our ability to predict outcomes. We have initial data showing, for example, that repeated VCT tends to increase our ability to improve outcomes, but we need more data on this. And then again, a very interesting aspect is monitoring response to treatment, as this has been not so easy to demonstrate that improvements in all of these biomarkers are associated with improvements in liver histology, and so in evaluating whether the drug is really working well or not. So with this, I am finished, and I thank you very much for your attention, and I'm open to any questions that you might have.